Elaine Decker,
Present, no COI.
Mohammed Faqih,
Present, no conflicts.
Judy Guzman-Cottrell,
Present, no commercial conflicts. I'm a consultant for Oregon Health Authority.
Pauline Kraft,
Present, I consult for Ferring Rebiotics and Series Therapeutics.
our guest, Michael Lynn,
Present, I have received research support in the form of contributed product from Option LLC and also Sage Products, now part of Stryker Corporation. And I previously received an investigator-initiated grant from CareFusion Foundation, now part of BB.
Sharon Wright.
Present, no conflicts.
Now we'll move on to the ex officio roll call. Lei Lin,
Present, no conflicts.
Scott Cooper,
Present, no conflicts.
Jimmy Reeves.
Conflicts.
Can you repeat that 1 second again?
Present, no conflicts.
Thank you. Tracy Olderidge,
Present, no conflicts.
David Henderson.
Present, no conflicts.
Now we'll move forward to our liaison representatives. You do not have to stay if you have conflicts. Paul Conway from AAKP. Patty Costello is not attending. Mark.
Sorry. Present, no conflicts.
Okay, thank you, Paul.
Yep, thanks.
Mark Rossi from American College of Occupational Environmental Medicine. Elizabeth Wick, ACS. Chris Lombardozzi from America's Essential Hospital.
Present, no conflicts.
Crystal Bowens, American Healthcare Association.
Present, no conflicts.
Nicole Anselmi, American Nurses Association.
Present, no conflicts.
Karen DeKay, Association of Perioperative Registered Nurses.
Present.
Mary Alice Lavin, Association of Professional of Infection Control and Epidemiology, APIC.
Present.
Emily Emerson, Association of State and Territorial Health Officials. Aaron Epson, Council of State and Territorial Epidemiologists. Ronald Myberg, ENV.
Present.
Gino.
CNV.
Perfect. William Avo, Infectious Disease Society of America. Benjamin Schwartz, National Association of County and City Health Officials.
Present.
Hannah Hinkle, National Rural Health Association. Eve Cooney, Organization for Safety, Sepsis, and Prevention. Karen Rabin, Pediatric Infectious Disease Society.
Present.
Thank you for joining. Lisa McGifford, Patient Safety Action Network.
Present.
Riza Mauricio, Society of Critical Care Medicine. Hillary Babcock, Society of Healthcare Epidemiology of America.
Present.
Stephanie Taylor, Society of Hospital Medicine.
This is Valerie Vaughn representing Society of Hospital Medicine.
Thank you, Valerie. Robert Sawyer, Surgical Infection Society.
Present, thank you.
Tiffany Wixton, the Joint Commission.
Present.
And if I've missed any liaison representatives, please, this is your time to announce yourself and organization. Okay, thank you for joining. I would like to establish quorum. We have met meeting quorum. We have not met voting quorum. Public comment is scheduled for after the presentation. When the comment period opens, the Zoom coordinator will provide instructions for how members of the public may provide comment. Public comment should be limited to 3 minutes, and we ask that you clearly state your name and organization for the record before providing your comment. Please note that the public comment period is not a question and answer session. Public comment will be after the presentations. And also, if you are not selected for public comment today, you can please submit your written public comment to the HICPAC inbox, which is hicpac@cdc.gov. All right, I'll hand it over to you, Alex.
Great. Thanks, Sydney, and welcome everyone to the August virtual HICPAC meeting. I'm going to just start off with a few quick announcements. Want to remind everyone that nominations for membership in the Healthcare Infection Control Practices Advisory Committee is open. Please, if you have suggestions, send those to our box at hicpac@cdc.gov before September 29th, 2023. Also wanted to highlight that we are now posting the HICPAC presentations to the HICPAC website. We will also be doing that for the presentations from today after the meeting, and we'll also be sending those out to all registrants after the conclusion of the meeting today. I also have a special announcement. We are still having some challenges with some of our packages for members. And so I think, as many of you recognize, we have not had a chair for the past meeting and this meeting. In light of the fact that we expect that to continue, we have elected to appoint an interim chair for the committee. So I'm happy to announce that Sharon Wright, who has been a member for a while, will be our interim chair probably from now until the end of the year. I think many people know Dr. Wright. She is the Chief Infection Prevention Officer for the Beth Israel Lahey Health System and is an Associate Professor of Medicine at the Harvard Medical School, is on faculty of the Division of Infectious Diseases at Beth Israel Deaconess Medical Center. She received her medical degree from the Columbia College of Physicians and Surgeons and her master's degree in public health from the Harvard School of Public Health. Dr. Wright is, in addition to her many other accomplishments, serving as the past president of the Board of Trustees for the Society of Healthcare Epidemiology of America. So we'd like to thank her for taking this on and assisting us through the rest of the year. And lastly, I did want to highlight one issue that we keep getting a lot of questions about, which is the HICPAC guideline process. To try and help with that, we have posted to the HICPAC website a timeline that kind of gives a sense of how the HICPAC process works. Did want to take just a few minutes to describe the high levels of that, as it is a long and complicated process, especially as it relates to the isolation guidelines. So I think, as you all are aware, the guidelines start usually with a work group, which is where we are with the isolation guideline, that works to try and resolve some of the issues and to adjudicate some of the more controversial points. The work group presents all these findings to the full committee, and which is the actual decision-making body that makes the recommendations to CDC. Once the work group is done with their process, those are again presented to the HICPAC committee for a vote, and then once approved, then those recommendations go to CDC, where they are reviewed again. CDC then, once approved at CDC or potentially adjusted, it goes to the Federal Register for public comment, which is obviously a critical part of the process. Once we get public comments back, that goes back to the work group to try and adjudicate the comments. And then those, once that's done, it goes back to the committee for an additional review and vote. Once approved by the committee, that's the stage that it finally goes to CDC for a final review and concurrence via our clearance process. And then if cleared, becomes HICPAC or CDC guidance. So again, just wanted to highlight that again. I'll refer you to the website if you'd like more details, but since we have received a lot of questions about that, I did want to just review that quickly. Okay, great. I think that's all for me. So I am going to turn it over to Dr. Wright to start the meeting. Dr. Wright.
Thanks, Alex, for the introduction. I am honored to serve in the role of interim chair of HICPAC. I'd like to move on to today's presentations, and I'll start by turning it over to Dr. Michael Bell for an update from the Division of Healthcare Quality Promotion. Mike?
There I am. Oh, hi, everybody. Apologies for the weird camera angle. We're going to try and zoom in just a moment. Just wanted to say a few quick things to underscore the process clarification that Alex just made. There's been some misunderstanding about where we are in the process. I want to be clear that we have not received presentation of draft language that is ready for a vote in any way. When we do, there will be a draft presented in the public meeting to this committee. And once that's voted on to be presented to CDC, then we will review it and then post it for public comment on the Federal Register. That'll be a 60-day period when we look forward to the input from everyone who has a stake in this. We are, sensitive to the fact that although we have multiple experts across the spectrum of occupational health, infectious diseases, and so on, we don't want to miss input that can be valuable. So we certainly look forward to that. Very excited to have all of the public participants on today. I apologize that the brevity of the meeting is such that we're not going to be able to hear from everyone who probably wants to comment. But as you heard from Sydney, please send your written comments in, and those will be included in the proceedings. So with that, I'll add one more thing, and this is by way of the usual division update. And there we have just a couple of things to touch on as we approach the end of summer, and with awareness of slowly increasing, still not high, but numbers of hospitalizations related to COVID, the concern about the respiratory virus season that includes RSV as well as potentially influenza. We are thinking through how best to capture information that's going to be helpful. The agency is working on a new respiratory virus index that will be refined over the coming weeks and should become available before the season begins. We are also in discussion about how we maintain visibility on things like bed availability at the community level that has been so important for the jurisdictions. And then lastly, we're looking at ways to monitor vaccine uptake in nursing homes and other health systems, as well as a return of vSafe. Some of you used vSafe with your original COVID vaccinations. As you know, the platform that we were using was donated. And so that was taken down, and we now have a more permanent platform being readied, and that should be up and running again in the coming several weeks. So again, autumn planning is really focused on respiratory viruses and making sure that we are as set up as possible to understand what's going on and then do something helpful about it. So with that, I'll hand it back to Sharon. Thank you.
Thanks, Mike. At this point, we will move to the first presentation, which is the Isolation Precautions Guideline Work Group Update. And I will turn it over to start off to my co-chair, Dr. Michael Lin.
Okay, great. Thank you very much for the opportunity to provide an isolation precautions work group update. I'll first start off with the important disclaimer that the findings and conclusions herein are draft and have not been formally disseminated by the Centers for Disease Control and Prevention and should not be construed to represent any agency determination or policy. I would like to acknowledge the Isolation Precautions Guideline Work Group members, which besides myself includes Sharon Wright as co-chair, Hillary Babcock, Elaine Decker, Judith Guzman-Cottrell, Anurag Malani, Joanne Reifschneider, Mark Rusi, Connie Steed, Julie Trevetti, and Deborah Yokoa. I would also like to highlight the ongoing support from CDC staff, including from DHQP and NIOSH listed here. The agenda for our work group update is as follows. We will briefly recap the June 2023 presentation, provide an updated timeline for work group activity, and present topics of enhanced barrier precautions and standard precautions, along with discussion questions for both topics. This slide provides a recap of topics discussed at our isolation precautions work group presentation at the last HICPAC meeting on June 8th and 9th, 2023. On day one, we presented work group recommendations for the guideline framework. We reviewed the framework for Section A, Overview of Transmission of Pathogens in Healthcare Settings, Section B, fundamental elements needed to prevent transmission of pathogens in healthcare settings. Section C, precautions to prevent transmission of pathogens in healthcare settings with evidence review. We also presented proposed transmission-based precautions framework for 1, transmission by air, 2, transmission by touch in healthcare facilities other than skilled nursing facilities, and 3, transmission by touch for skilled nursing facilities. On day 2, we discussed enhanced barrier precautions and specifically criteria considerations that we'll revisit today. I would like to provide an updated timeline for guideline development, HICPAC discussion, and vote. The rationale for the updated timeline is to provide opportunity to review feedback and address unresolved issues. The work group thanks this committee, its liaisons, and the general public for feedback during the June 2023 HICPAC meeting. The work group thanks the CDC HICPAC Long-Term Care Post-Acute Care Work Group for feedback. The work group also thanks additional CDC NIOSH subject matter experts for their feedback to the work group. For our timeline, the HICPAC virtual meeting today will be to discuss issues around enhanced barrier precautions and standard precautions. The HICPAC meeting, which is in person in November 2nd to 3rd, 2023, will be the tentative target for the HICPAC review of a draft guideline and vote. If approved, the committee's recommendations will be sent to CDC for review prior to public comment period. Now we will discuss enhanced barrier precautions. In the June 2023 HICPAC meeting, the work group presented a draft framework for enhanced barrier precautions implementation in skilled nursing facilities for discussion. Today, we present updated language for the enhanced barrier precautions criteria. First, some background. Enhanced barrier precautions refers to the use of gown and gloves by healthcare personnel in skilled nursing facilities during high-contact resident care activities that provide opportunities for transfer of multi-drug resistant organisms, or MDROs, to staff hands and clothing. Examples of high-contact activities include dressing, bathing or showering, transferring, providing hygiene, changing linens, changing briefs or assisting with toileting, device care or use, and wound care. It takes into account the special circumstances of care in a nursing home, for example, a home-like environment, and barriers to implementing contact precautions, such as restriction to the resident's room. In 2019, CDC introduced enhanced barrier precautions as a personal protective equipment approach to apply to residents with infection or colonization with novel or targeted MDROs when contact precautions do not otherwise apply. In 2021, the HICPAC white paper added consideration of applying enhanced barrier precautions to residents with wounds or indwelling medical devices, regardless of MDRO colonization status. Supportive evidence for enhanced barrier precautions includes several studies that demonstrated that high contact activities were associated with gown or glove contamination of healthcare personnel. Furthermore, a pilot study with a 2-month baseline and 2-month intervention design of targeted gown and glove use for residents with wounds and devices in 2 nursing homes demonstrated a significant decrease of Staph aureus acquisition among residents, from about 16.8% to 6.7%. Shown here is a draft framework for transmission-based precautions to prevent transmission by touch for skilled nursing facilities. There are 2 precautions presented in the rows: contact precautions and then enhanced barrier precautions. The yellow highlights identify specific wording that we will discuss. Contact precautions in skilled nursing facilities would involve gown and glove for all activities for any entry into a designated patient space. Dedicated medical equipment would be required. Single occupancy would be preferred. If not available, then cohort. Example applications would be organisms specified in Appendix A, such as norovirus, Clostridioides difficile, and scabies. Contact precautions would also be indicated during MDRO outbreaks in a time-limited fashion. Enhanced barrier precautions involve gown and glove use during high contact patient care activities. When contact precautions do not otherwise apply, enhanced barrier precautions will be indicated for residents with infection or colonization with an MDRO. Enhanced barrier precautions would be considered for residents at high risk of MDRO colonization, regardless of known MDRO status. For example, residents with wounds or indwelling medical devices. Dedicated medical equipment would not be required. Clean and disinfect equipment between residents for standard precautions. Single occupancy would not be required. Example applications would be MDROs targeted by CDC, such as carbapenem-resistant organisms. One note, the enhanced barrier precautions framework here will make the first indication for residents with infection or colonization with an MDRO a definitive recommendation based on the recognition that this approach would be resident-centered, particularly with the allowance for residents to leave their rooms. It would make the second indication of residents at high risk for MDRO colonization a consideration rather than a definitive recommendation, reflecting the promising but limited evidence and experience with such a risk-based approach. I'd like to take this opportunity to invite feedback now for discussion. The first topic would be feedback on the enhanced barrier precautions indications as currently proposed. The second topic is for contact precautions in healthcare facilities, both skilled nursing facilities and non-skilled nursing facilities, with feedback on the use of term designated patient space. Most commonly, designated patient space would represent a patient or resident's room, but would allow application to a broader range of patient care areas in healthcare facilities. For example, post-procedure recovery areas or infusion centers. So I'll take a moment now just to invite feedback. Thank you very much.
Erica Shinoy.
Hi, thanks so much. Could we go back to the last slide and just so I can look at it while we're going through this? So thank you so much for this work. The first comment I have is on the indications, and it's actually related to that first indication for residents with infection or colonization, and it's about the single occupancy piece. And I just want to understand if that means that one could cohort discordant MDROs under the enhanced barrier precautions definition, so CORIS with CRE. Is that the concept there? Is that permitted by this?
Okay, excellent question. I think that in the ideal situation, you're absolutely right. I think facilities will have a lot of leeway in terms of separating MDROs and cohorting based on like type. That certainly is the optimal situation. I think given that enhanced barrier precautions is more of a long-term approach, I think there will be more flexibility in terms of potentially residents having a mixing of different types of MDROs within the same room. So at least as it's written right now, there is some flexibility, but we can look into that question in more detail about whether that should be specified any further. It's an important question. I will just comment that even carbapenem-resistant organisms, as you know, oftentimes we may have a phenotypic or resistance definition of that particular organism, but we may not know the actual mechanism, which is epidemiologically important. So there are challenges to cohorting over a long term that may be just limited by the ability of the labs to be able to identify mechanisms. So I think there is an intent that with enhanced barrier precautions and using gown and glove for high contact activities, that would reduce spread.
Thank you. And then I had just two more comments on those other pieces. So the other was related to the designated care space. And if there was consideration, I appreciate that addition from our conversation back in June. My question was whether or not there was consideration for not just entry, like crossing the threshold of some designated space, but really focusing on gown and glove use for contact with the patient or the patient's environment. There are many instances in which you might enter a patient care space, but not actually touch the patient or touch the patient's environment. And so this could reduce the use of gowns and gloves for those activities. That's my comment on that one. And then the last comment, I think you were asking, maybe clarify if there is a question about applied enhanced barrier precautions in outside of skilled nursing facilities. I think that was a question. If it was, my recommendation would be a consideration for other congregate care settings with similar sorts of activities and setup, like behavioral health or other facilities where they might benefit from this approach.
Thank you for those comments. I think I'll just touch briefly on the designated patient space and your question about crossing the threshold. The intent of contact precautions is to use gown and glove when there is contact with the patient or the environment. And so, as you know, facilities have operationalized that in different ways, some recommending or mandating that as soon as you cross the threshold, that even if you're not intending to touch the patient or the environment, that you wear gown and glove for contact precautions rooms. The use of the term designated patient space could allow for some flexibility in designating a safe zone that I think some hospitals have used. Again, with the intent that we are using contact precautions to prevent touching of the healthcare personnel to patient or environment. So if there's a way to be able to operationalize that, I think the term designated patient space, in my opinion, might allow for some of that flexibility.
Thank you.
See a hand up from CDC conference room.
Yeah, thanks, Mike. Just taking a moment to be very clear here, even in skilled nursing facilities, if contact isolation is required, for example, during a CRS outbreak, we expect contact precautions to be used. The enhanced barrier precaution approach is not a replacement for contact precautions, but instead it's a way of driving better implementation of what really should be under standard precautions, which we'll talk about in a minute. But we expect someone, if they're going to be soiled by doing a procedure, would appropriately use gowns and gloves as indicated for that procedure. In this instance, we're saying that if someone is likely to be colonized, we don't want you to make that decision on your own. We want you to simply wear gown and gloves when you're handling that device or wound or doing that close contact care. And so it's really sort of an aggressive version of standard precautions as opposed to contact isolation, where you really do seal everything into one space. And that, I think, is an important point for people to be thinking about, because it is the opposite of some of the the things that I've seen circulating, and I think that that's kind of missing the point. So I just wanted to underscore that for you.
Thank you, Mike, for clarifying that. Dr. Abel?
Hi, good afternoon. I am the liaison for IDSA, but I'm going to be speaking on my own behalf. And I appreciate that the difference, that we're trying to make with these designations, but the challenge is operationalizing it. And when I'm thinking, in a long-term care environment, and you have an environmental service worker, and you're trying to standardize this distinction, what are you going to tell the EVS worker? Do they need to wear or not gowns in order to clean and be in contact with the environment? Because they're not providing direct patient care, they're not changing the wound, but they are cleaning. So if this patient is a CORS patient on enhanced barrier precaution, what are we going to tell the EVS worker? Do they need to wear PPE or not? And what type of disinfectants are they going to be using? So I just want to make sure that we take that into consideration, because I think we're thinking very much physician and nurses, but there are other people, respiratory therapists, environmental service workers, nutrition. When we do our infection prevention is go out and do monitoring, the first thing they do is like, didn't you see the sign? You walked into this door, you walked into the patient environment, and you were not wearing PPE. And these are the workers that are going from room to room, delivering care as well, EVS, nutrition, etc. So I just want to make sure we take this into account where we frame this in order to make sure that we are able to operationalize the implementation of these recommendations. The other question was, some of these patients are going to be going to common areas, rehabilitation, for example, or nutrition rooms and dining halls. So if you're in contact precautions today, we're telling you you're not going to be able to go to the dining hall and eat with the rest of the nursing home residents or the long-term care facilities. But if you're an enhanced barrier, you are allowed.
That's correct.
Okay, so the Candida auris patients that were OCD, nobody touching the environment, do not share equipment. Oh, it's okay. You can go and eat with everybody else in the dining room. So I just want you to understand that we're sending some mixed messages, and this is what I end up getting from the nursing homes and from our inpatient rehabilitation facilities. They feel that why so much compulsion when you're touching the patient environment, but then we're allowing that patient to go out and touch everything around them.
So, Dr. Alba, I'll jump in very quickly. So it's probably important that we review the actual words again, because there's some details in the language that I think address some of what you're raising. First and foremost, if a nutrition worker or an EVS staff member is going to do a wound dressing change or handle a catheter bag or help the patient dress or do toileting, they too would have to use PPE, because enhanced barrier precautions is about the activity. The difference between enhanced barriers, and so that's like standard precautions, where if you're going to touch something, you wear gloves. If you're just going in the room, then you're not going to be helping the person get dressed or change a wound dressing. You shouldn't have to wear anything. So I think that is, the context for that first half of your concern. The second one is what I said at the beginning. If somebody has Candida auris, they need to be on contact isolation, full stop. And then they would not be going to the cafeteria. But if somebody happens to have a wound that is dressed, but needs to be maintained and cared for, the person handling that wound needs to wear gown and gloves, but that individual does not need to be locked into their room when the wound is dressed and managed appropriately. So this is a way to have somebody who happens to have a wound, right, be able to have a normal quality of life in their residence, which happens to be a nursing home, but at the same time ensure that anyone handling that wound or its dressing uses appropriate PPE to keep from contaminating themselves or carrying organisms to another person.
And I appreciate that distinction. I just want to make sure that we do the wording, it's third grade level, because it's always the devil is in the details when you're trying to operationalize and implement these little things. And in addition to that, when these patients get discharged from these facilities and they go home, they don't follow any of these. And then they show up in our clinics with no barrier precautions. We see them in clinic just like we would see any other patient. So I understand that what we're trying to do is limit the transmission and the horizontal transmission within facilities. Many times when the worker goes into the room, they don't know what the patient may need. You may walk into deliver a tray and then the patient says, I need help with this. So that's where the distinction comes. When you're walking in the threshold, you don't always know what kind of, you come in with one intention, you may end up with another one. The nurse may come in with the intention of just checking on the patient, and then the pump is beeping and then they are touching the pump. And that's a typical question that we always get. Do we need to gown and glove just to touch the IV pump, or just hand hygiene is enough? And I'm going to pause here because I know there are others.
Okay, no, thank you very much. And I think a lot of these operationalizing questions are on the CDC frequently asked questions website for enhanced barrier precautions, because enhanced barrier precautions has been implemented already for several years. And so these implementation questions are excellent and the ones that have been raised by staff and by leadership. So thank you. Lisa McGifford?
Yeah, I just wanted to generally reinforce what was just said about being real specific about operationalizing and thinking about it. It's one thing to think about it from the worker's perspective, which is a lot of what we heard at the last meeting. But we also need to think about it from the employer's perspective, the hospital owners, the nursing home owners. Those are the people who are going to essentially provide the support to implement these. And if they are not fully understanding what is required, if it's sort of loosely, this is what you should be doing and that kind of thing, the language needs to be really clear and imperative. And I know that the CDC doesn't have the authority to require certain things, but CDC has the standing to say, this is what everyone should be doing, and this is what you should be doing in order to maintain safety for your workers and your patients. Thank you.
Thank you for the comment. Mary Alice Lavin? Oh, you're on mute.
Sorry. Thanks, Mike. I just wanted to say thank you for the separation of indicated for and considered for, because as we've implemented this in many Illinois facilities, that seems to be quite frequently where people get stuck. And so stating clearly that it's indicated for someone who is infection or colonization, but considering it for others that are at high risk for acquisition, I think will be helpful for facilities when they implement. And to the point that the two previous points that were just made, it will be extremely important, and we have found that it is very important that the facilities completely train their staff before they implement, so that some of the nuances that have been discussed need to be built into that training in order to make sure that everyone understands what the expectations are. Thank you.
Thank you for the comment. Are there other comments about this section? We can certainly circle back, but at this point, then I'll pass the slides over to Dr. Wright, and she'll continue with the next topic, standard precautions.
Thanks, Mike. Can you go to the next slide, please? Oh. So the goal of this part of the discussion is to discuss whether aspects of standard precautions should be updated for the 2024 guideline. Next slide. Just to review a few key concepts, standard precautions are the basic practices that apply to all patient care, regardless of the patient's suspected or confirmed infectious state, and apply to all settings where care is delivered. Standard precautions have multi-directional benefits. They protect both healthcare personnel from acquiring infection from patients and prevent healthcare personnel or the healthcare environment from transmitting pathogens to patients. Next slide. So the evolution of the term standard precautions and the contents of it has really changed over time. And so we just wanted to briefly review that as we consider whether any changes are necessary. So although the isolation techniques for use in hospitals has existed since 1970, the concept of standard precautions really began in earnest in the 1983 CDC guideline for isolation precautions in hospitals. And this document provided two systems for isolation, not all that different than what we do now, category specific and disease specific. And it was in this document that the blood precautions, which were first introduced in the 1970s, were expanded to include body fluids. And the isolation category that it was created was named blood and body fluids. And this also emphasized decision-making by the user as to what was needed, similar to standard precautions today. From 1985 to 1988, universal precautions was used, and that was really developed in response to the HIV/AIDS epidemic, and importantly dictated the application of blood and body fluid precautions to all patients, regardless of their infection status. However, it didn't apply to certain body fluids, such as feces, nasal secretions, sputum, or urine, unless they were contaminated by visible blood. And they added personal protective equipment to protect healthcare personnel from mucous membrane exposures, as well as specific recommendations for handling needles and other sharp devices. In 1987, an additional concept was added of body substance isolation, which emphasized avoiding contact with all moist and potentially infectious body substances except for sweat, even if blood is not present, and shared some features with universal precautions, but not all. It also was a little bit weak on transmission by large droplets or by contact with dry surfaces. And so that was kind of an addition to universal precautions. In 1996, the guideline for isolation precautions in hospitals was prepared by HICPAC. And in addition to the transmission precaution categories, it melded the major features of universal precautions and body substance isolation into standard precautions to be used with all patients at all times. So that was really the first time the term was used. In 2007, the guideline that we are working on updating now, that was the guideline for isolation precautions, preventing transmission of infectious agents in healthcare settings, continued the use of the standard precautions category with a few updates to include additional components such as handling of textiles and laundry and environmental disinfection. In 2017, HICPAC put out a white paper about core infection prevention practices for safe healthcare delivery. And it really selected from all healthcare infection control guidelines those that were intended to serve as a standard reference or a standard of care that was anticipated not to likely be updated or changed based on additional evidence coming forward. And so this was really an attempt to outline a core set of infection prevention and control practices that are required in all healthcare settings, regardless of the type of care provided. And then in 2022, as was presented at the meeting in November, the core practices moved from this HICPAC recommendation to CDC guidance, and a webpage was created. And it was really intended to become the main reference for standard precautions. It also links out to a webpage on standard precautions for more details, although that was last updated in 2016. There were no intended changes in standard precautions at that time, but it seems to have a focus on application by frontline staff. For example, there's less emphasis on things like textiles and laundry. And it included new areas based on lessons learned from COVID-19 and other outbreaks. For example, broadening the minimizing potential exposure section to include early detection and management, as well as considering universal masking during periods of high respiratory virus transmission, and explicitly stating things about prepping medications in clean areas, for example, not adjacent to potential sources of contamination like sinks. So that's the background just to keep in mind as we start to dive a little bit deeper into standard precautions. Next slide, please. So this is just to visually show you that there's not complete overlap of the standard precautions emphasis and in the standard precautions website and on the core practices guideline. Obviously, there's much more, as you can see on the right of the core practices rectangle that are not a part of standard precautions, but very important for infection prevention and control. The standard precautions has almost complete overlap with core practices. But as I mentioned, there are three areas that are not in as much detail or in the core practices. And that's handling textiles and laundry carefully, proper handling of needles and sharps, and patient placement. All of the standard precautions elements are contained in the current 2007 isolation guideline, and that is part of why we're bringing it up today to make sure that all of these pieces have homes if we feel that they're still important. Next slide, please. So this is just a little bit more detail of what's in the 2007 guideline currently. On the left, you can see the different components and some description on the right. So hand hygiene is emphasized pretty extensively in core practices and in the 2002 hand hygiene guideline. The PPE focuses on risk assessment with use of appropriate PPE based on activities being performed, and that's in both documents. The patient care equipment focuses on reprocessing of reusable medical equipment between each patient or when soiled. The care of the environment focuses on environmental cleaning and disinfection. The textiles and laundry is also referenced in the environmental infection control guideline. The needles and other sharps includes things that are very specific, for example, avoiding recapping, and those are the pieces that are not highlighted as much in the current core practices. The patient placement has a focus on things like transport and cohorting, and then the respiratory hygiene and cough etiquette and standard precautions is in the minimizing potential exposure section. And the safe injection practices, as I mentioned, is really about like single-use disposable needle per injection and avoiding the use of single-dose vials. The use of masks for insertion of catheters or lumbar injection procedures that's in the 2007 guideline is now combined with the safe injection practices within core practices. Next slide, please. So what we'd like to discuss with HICPAC today, three components, as I highlighted, were added to standard precautions in the 2007 isolation guideline. Are there components that should be added or removed from standard precautions? And additionally, are there other modifications to standard precautions that should be considered, including the name? So I'll open that up for discussion. And in case it's helpful, I think we have a crosswalk on the next slide. I'll just orient you to it for a second before we take comments. In the first column on the left, you can see the 2007 isolation precautions guideline categories that we just went through. In the middle column, the CDC core practices standard precautions, how that maps over to what's in the isolation precautions guideline. And you can see those three central ones, although there may be included in some of the sections, there's not as much detail. And then some just additional notes to consider for 2024 guideline, and also outlining where the core practices and the isolation precautions guideline links out to. For example, for textiles and laundry, there's a link to the environmental infection control guideline. The needles and other sharps could be added more explicitly in the occupational health section of core practices. And then the patient placement is mostly in the 2007 guideline, and in fact is referenced by core practices currently. Erica Shinoy.
Hi, thank you for going through all the history here. Can I just clarify the question? Is it when you look at the three in the middle, should they be brought into standard precautions, or should anything in standard precautions be moved out? Is that the question you're asking the group?
Yeah, not just those three. I think really whether we think standard precautions is still important in its current formulation, and we want to make sure that we don't lose anything that might only be contained in one document or the other, particularly if core practices is now designated, since it's a CDC guideline, as the home for standard precautions. We want to make sure that pieces aren't lost. And then if there are pieces that we feel are not critical to standard precautions or belong in another document, to have that discussion here.
Okay, that's helpful. I would say that of these, I think not losing textiles and laundry is important in the transition. And then patient placement, I think, is very specific generally to the pathogens, and therefore I don't really think of it generally within standard precautions. So I think it kind of makes sense to not be considered part of standard precautions since it's covered elsewhere. And then let me just clarify the needles and other sharps. Sometimes these are bucketed in with safe injection, but there are different concepts there. Partly it's the protection of the healthcare worker, and then there's also the protection of the patient. So is your proposal here to think of needles and other sharps separate from safe injection practices, or to collapse them and cover the occupational health and then the patient safety components?
I think we haven't settled on a particular thing. We were thinking that there is an occupational health section in core practices, and it could be incorporated in there. And in fact, the intention may have been that it is in there. It's just that it's not highlighted. So we agree that potentially that section could be enhanced so that information wouldn't be lost, at least in that level of detail.
Thank you.
Mary Alice.
Thank you. I just have a comment about separating them out. Oftentimes, when conducting ICARs and that discussion comes up, many facilities perceive it as the occupational risk and really don't have a concept of the safe injection practices for the patient or resident, and all the things that you have included there about single use and some of the other issues. So I think it would be helpful to have them in two separate categories.
Sorry, just to make sure I'm understanding your point. Yeah, I think we agree that they should all be, both types should be included in standard precautions. You're making the point that the needles and sharps should be its own section?
included under the occupational health.
Under the occupational health.
Yes. I think that distinction will make it clear that there is a component that relates to occupational health, but there's a separate component that many facilities don't necessarily recognize about the safe injection practices that protect the patient or the resident.
And just to clarify, those safe injection practices are in core practices already. It's the piece about the sharps handling that isn't highlighted in the same level of detail, but I don't think it was intended to be lost. It's just in more detail in the current 2007 guideline.
Okay, thank you.
Judy Guzman-Cottrell.
Hi, thanks, Sharon. I wanted to thank Sharon and Michael for bringing up the second question because it's a question that I've asked a couple times. I'm a HICPAC member, but I'm also serve on this work group. And the second question is regarding the term standard precautions. And I just wanted to highlight that question because I see, that many of us who work in infection prevention often say, many healthcare personnel don't seem to understand standard precautions, or even worse, that employees think that standard precautions means do nothing. And, this problem should obviously be addressed by more education and training of our healthcare workforce. But, I just think that since we're taking the time to review the contents and revise some verbiage within the 2007 guideline, that we should also take the opportunity to consider or at least address renaming this term, because we all know that standard precautions is the critical cornerstone of preventing HAIs. And, after thinking about this for many months, my concern is that the term standard precautions is actually potentially too complex for all levels of healthcare personnel to really immediately understand what we're trying to convey. Or maybe it's not too complex, but it's too vague. And so I wanted to just, ask, raise that question. Is there a better term out there that both captures the main objective of standard precautions and, more importantly, would be more immediately understood by all healthcare personnel? I don't have a great list of suggested new terms. Our work group hasn't come up with that. I'd suggested the term every patient precautions, or EPP, to the work group. But I don't know. I would, as a work group member, I'd love to invite all of my HICPAC colleagues to ponder this topic and, of course, come back to the work group with any suggestions. And in fact, I'd invite suggestions from anyone who works in HAR and AR prevention, because I think there's many, many of us out there who think about this term. And, it'd be great to hear ideas. Thanks.
Thanks so much, Judy, for sharing that. Tiffany Wixton.
Hi, good afternoon. So as I look at the three different categories that are kind of on the sideline that don't overlap with core practices, it kind of makes that awareness that those actually belong under OSHA bloodborne pathogen standard. And for a long time, the implementation of standard precautions often was highlighted as, if you're meeting standard precautions, you're meeting the essence of OSHA bloodborne pathogen standard. So I wonder if there is a place for including linens, including sharps safety, because it appears that those are all part of universal precautions for OSHA bloodborne pathogens, which was kind of that progression of how standard precautions was developed initially.
Thank you for that comment. Any other comments or thoughts on Judy's question as well?
Sharon, I'll just, on behalf of our colleagues to the north, remind us that there they use routine practices. And, sort of have used that routine word. There's certainly always benefit in harmonizing across borders. So that's, if we really are leaning towards fresh nomenclature here, that might be an option. Then there's the EPP, which we were waiting for, Judy. Other ways of garnering additional attention and focus on these sort of constant requirements for safety, I think would be welcome. I appreciate also what I think Elaine might be saying, which is that we need to hammer home standard precautions because that's the thing that everyone's used to. I don't think we at CDC have a preference. I think this is where robust conversation would be particularly helpful in terms of sharing additional options or ways, if we're going to keep the existing terminology, to make it more effective.
Thanks, Mike. Elaine Decker.
Hi, I'm sure Judy was expecting this as Mike was. I'm going to do point counterpoint. I am a huge believer in the term of standard precautions, and I've been teaching them for many, many years in the classroom setting as well as the real world setting. And the way I've kind of looked at this is it's a standard of care. And I teach them as these are our basic standards of care that we should be doing for all patients. And it will keep the employee and the patient safe from pretty much everything except. And then I go into those things that require droplet or airborne. It has been more successful in some facilities as compared to others. And I do better in smaller places where they do support and have time for in-person education or are able to include it in staff meetings and things like that. It's harder when you're working in a large facility because there's so many people. But I think that if we focus on standard of care and using them for everybody, and then really help put out good educational tools that can be used by the IPs in the field, I think that's a good way, because even if you change the name, you still have to teach. And I'm really a huge believer in trying to get more time for IPs to teach staff these core measures and these standard precautions, as well as transmission based. And I think that's where we need to be focusing and driving for. Because for those people who've learned it, it would be unlearning something and they would be like, well, why? And it would be hard to explain when we're not changing the content, why we're changing the name. I think it would confuse some people. And that's my counterpoint.
Thanks, Elaine. Any other comments?
I can just add one thing. I think, Elaine, you mentioned standard of care as a name that you like to use for teaching. And I do want to ask as a follow-up, were you intentional in terms of dropping the term precautions as you were teaching standard precautions? Because there is some discussion about the term precautions as it exists in standard precautions that itself could be confusing, because as we talk about transmission-based precautions, there's at least some tendency to say, well, now that someone's on contact precautions, that has replaced standard precautions.
I never got rid of the term standard precautions. I said, consider this as an equivalency. Standard precautions means your standard of care for all patients. The precautions word to me is very important as well. These are the precautions that you're taking as you're interacting. These are the precautions that you're taking based on your risk assessment of what you're about to do with that patient or what you're about to encounter in their environment. So it was more, think of these things as why you're doing them, but the precautions part was critical for, just as you mentioned, be on the alert as you're in the room. Things may even change while you're in the room. You might think I didn't need a gown, and now all of a sudden you do. So we're trying to make gowns more readily available in patient rooms as well as gloves. So a lot of things going on as we've learned over the years, how things can change so quickly.
Thank you.
Okay. I don't see any other hands up. Trying to scroll the list. I can't tell if there are any other ex officios or liaisons or members who have questions. Okay. Mike, maybe we can go to the next slide. So for next steps, as Mike Bell mentioned earlier, our goal is to have a draft precautions document to present to HICPAC for review, discussion, and vote during the November 2023 meeting. Next slide. And again, I'd like to echo Mike's comments in the beginning, thanking everyone here today for their comments, as well as all of the subject matter experts who have been weighing in throughout, and will be coming to you with more in November. Thank you. Okay. Mike, maybe, thank you. Next up, we're going to hear a presentation from Colleen Kraft on the Healthcare Personnel Guideline Workgroup update.
Thank you. I'm just trying to make it so it looks correct for everybody. Do you see my notes or you do see my notes?
It's in presentation mode, so we see your notes.
Okay. How about now? Okay, thanks, Jenny. All right, so I'm going to be giving an update on the Infection Control and Healthcare Personnel Work Group. The findings and conclusions are draft and have not been formally disseminated by CDC and should not be construed to represent any agency determination or policy. So again, as we remind you during this presentation every time, this is an update from 1998. So this is our goal and our charge. So our goal was to provide updated information on infection control and healthcare personnel. And this work group has been focusing primarily on pathogen-specific issues for infection control and healthcare personnel. Where the evidence is out of date, the work group has been making updates using evidence-based methods when the evidence is available. So our current status report for Section 1, that was published in 2019, as you might remember. For Section 2, this is the epidemiology and control of selected infections transmitted among healthcare personnel and patients. We really recently, or at least in 2021, published diphtheria, group A strep, meningococcus, and pertussis. Rabies was published in November of 2022. You can find these at these links. Our current progress is as follows. Measles, mumps, rubella, and varicella sections have completed clearance and are posted to the Federal Register. The deadline to submit public comments about these guidelines is September 15th, 2023. The pregnant healthcare personnel section completed the 60-day public comment period and received one comment in support of the guidance. Cytomegalovirus and parvovirus B19 sections are in clearance, and the conjunctivitis section will go into clearance very soon. Staph aureus is pending a literature review. The group has begun section scope determination for the gastroenteritis section. And then on deck coming up is scabies, pediculosis, hepatitis A, bloodborne pathogens, herpes, tuberculosis, and viral respiratory infections. So to go a little bit more deeper in some of our updates for the pregnant healthcare personnel, as I already mentioned, it completed the second 60-day public comment, and that one comment was from the Association for Professionals in Infection Control and Epidemiology, which was in support. The public comment read, the Association for Professionals in Infection Control and Epidemiology, APIC, wishes to thank the Centers for Disease Control and Prevention for the opportunity to provide input to the CDC draft guidance, infection control in healthcare personnel, epidemiology, and control of selected infections transmitted among healthcare personnel and patients, pregnant healthcare personnel. APIC is a nonprofit multidisciplinary organization representing 15,000 infection preventionists whose mission is to advance the science and practice of infection prevention and control. We thank the CDC and Healthcare Infection Control Practices Advisory Committee, HICPAC, for your work on this document, and you have our full support for the document as written. Look forward to continuing our work with CDC to prevent hospital-acquired infections in healthcare facilities. So the draft recommendation currently is do not routinely exclude healthcare personnel only on the basis of their pregnancy or intent to be pregnant from the care of patients with infections that have potential to harm the fetus. For example, CMV, HIV, viral hepatitis, herpes simplex, parvovirus, rubella, and varicella. No changes have been made, proposed or made since the committee last voted on this draft guideline. A final vote will be held today, and if approved, the section will be submitted for final CDC clearance and subsequent posting to the CDC Infection Control Guideline website. I'd like to acknowledge every member of this work group committee and the CDC support that we receive. We'll open it up for discussion and comments, questions.
Colleen, while people are thinking about their questions for you, I just want to clarify that we will not be voting today since we don't have quorum.
Yes, thank you. Sorry about that.
While people are thinking, I'll just foreshadow for our larger audience that the process that the healthcare personnel document has been going through for now a number of years, marching through each of these clumps of pathogen types, looking at the evidence and then making a recommendation for those pathogens, is what will begin after this initial phase of the isolation guideline is completed. So we have all of Appendix A in the isolation guideline that goes pathogen by pathogen that will undergo this process to determine what is recommended for those diagnoses. And that is something that is likely to take a couple of years. But for those of you who are new to this process, what you're seeing today is the end of one small segment, the healthcare worker piece, and then you see that there are other tranches of infection-related categories that are still to come.
Thanks, Mike. Any questions or comments for Colleen on her presentation? Thank you. We will now move on to the presentation on U.S. Public Health Service Occupational Post-Exposure Prophylaxis Guideline by Erin Kaufman.
Thanks, Dr. Wright. I'm just going to share my screen. And can you all see my screen okay?
Yes.
Okay, wonderful. Well, thanks so much for the opportunity to present today. My name is Erin Kaufman, and I'm in the Prevention and Response branch of the Division of Healthcare Quality Promotion. What I'll be presenting on is the U.S. Public Health Service guidelines for the management of occupational exposures to human immunodeficiency virus, or HIV, and recommendations for post-exposure prophylaxis. And this is a draft update that's currently in the works. So brief agenda here. First, we'll just go over the background and rationale for this update. Then we'll review the summary of the key draft recommendations. And at the end, I'll have some time for questions. So just to give a bit of brief background, the guidelines developed by the U.S. Public Health Service were last updated in 2013. And at that time, the key recommendations included first, the use of raltegravir or Icentrus plus Truvada or tenofovir disoproxil fumarate and emtricitabine as the first-line PEP regimen. With other 3-drug regimens recommended as alternatives. An option was also provided to conclude exposed healthcare worker follow-up HIV testing at 4 months if there was the use of the 4th-generation HIV antigen antibody test, and otherwise testing was concluded at 6 months. So what's changed since 2013? Well, first, we've had the availability now of new antiretroviral agents as well as regimens. Most notably, this includes a number of 2nd-generation integrase strand transfer inhibitors, also known as INSTIs, which have higher genetic barriers to resistance. And this class includes dolutegravir, which was approved in 2013, shortly after the last guideline update, as well as bictegravir, which was approved in 2018. Second of all, there's the advent of the principle of undetectable equals untransmittable, or U equals U, in the field of HIV prevention, with data demonstrating the protection that undetectable viral loads afforded sero-different partnerships. Third, and this really isn't so much of a change as more of a continuation, we've had no new documented occupational transmissions of HIV. And lastly, the first FDA-approved qualitative nucleic acid test, or NAT, for HIV diagnosis was approved in 2020. This has the shortest available diagnostic window for HIV, and it's able to detect infection within 10 to 33 days after exposure. So with all of that said, this update was essentially an opportunity, first of all, to update recommendations for PEP regimens to include the latest ART agents. Second, we took the opportunity to review the risk for transmission from patients with undetectable viral loads, the diagnostic testing timeframe, and the interval from exposure after which there was no benefit to determine if updates were merited in any of those areas. And lastly, our goal is also to align as much as possible with our updates with forthcoming recommendations from the CDC Division of HIV Prevention as non-occupational PEP guidelines, which are also forthcoming. Just wanted to lastly give you a brief sense of our timeline. So we actually started this effort back in February of last year, which involved the formulation of a working group with representatives from CDC, NIH, FDA, and HRSA. We identified performed a targeted, we identified key questions for update and performed a targeted systematic literature review where needed, drafted an initial set of recommendations that are preliminary, as well as presented to an outside expert panel for feedback. And so today, about a year and a half later since the beginning, we're presenting these draft recommendations as they currently stand to HICPAC. Following this presentation, the goal is to finalize the draft of recommendations for posting in the Federal Register to receive public comment. And then following that, we will incorporate those comments from the Federal Register, hopefully around the turn of the 2023 to 2024, and then hope to submit this updated guidelines for publication somewhere around spring or so of 2024. And again, concurrently, our goal is to align these recommendations with updates that are ongoing to the non-occupational PEP guidelines. So with that, I'll move over to the summary of our draft recommendations. I'll read these off the slide. If you see anything in bold, it's a new draft recommendation. Otherwise, it's essentially just a restating or a reclarification of the same recommendation that existed in 2013. So first here we have the draft recommendations for the management of healthcare personnel with an occupational exposure to HIV. First, healthcare personnel should report occupational exposures to blood and body fluids as soon as possible to occupational services. For healthcare personnel who have an occupational exposure to HIV, PEP should be initiated as soon as possible, up to 72 hours after the exposure and taken for 28 days. Initiating therapy after a longer interval might still be considered for exposures that represent a high risk of transmission. And whenever possible, the HIV status of the source patient should be determined to guide appropriate use of HIV PEP. Additionally, administration of HIV PEP should not be delayed while waiting for the source patient's test results. If HIV PEP is initiated by the exposed healthcare personnel and the source patient is later determined to be HIV negative, PEP should be discontinued and no further HIV follow-up testing is indicated for the exposed healthcare personnel. Reevaluation of exposed healthcare personnel is recommended within 72 hours after occupational exposure to assess for further counseling needs for exposed healthcare personnel, as well as PEP tolerability. And recommendation to provide counseling to exposed healthcare personnel in accordance with CDC recommendations for healthcare personnel with occupational exposures, including counseling on the importance of adherence to HIV PEP. So next, I'll discuss the draft recommendations for the management of pregnant or breastfeeding healthcare personnel with an occupational exposure to HIV. So the decision to offer HIV PAP to pregnant or exposed breastfeeding healthcare personnel, I should say exposed pregnant or breastfeeding healthcare personnel, should be based on the same considerations that apply to any healthcare personnel who sustained an occupational exposure to HIV. Additional counseling of exposed breastfeeding healthcare personnel should include risks and benefits of continued breastfeeding while taking PAP and while being monitored for HIV seroconversion versus interrupting breastfeeding. So next, wanted to go through the draft recommended regimens that will be part of this update. So here we have the draft preferred HIV PAP regimens. There are two options here. Both consist of an INSTI plus 2 NRTIs. So the first option is Biktarvy, which is 1 pill once a day by mouth, and that is a regimen that consists of bictegravir plus tenofovir alafenamide plus emtricitabine. Or another preferred option would be dolutegravir or Tivicay. And I won't read out the dosages just for kind of ease of listening to this, but you can see them on the slide. Otherwise, it'd be dolutegravir plus emtricitabine or lamivudine plus either tenofovir alafenamide or tenofovir disoproxil fumarate. And the new recommendation to include bictegravir and dolutegravir containing regimens as preferred HIV regimens stems first from a sort of a systematic literature review that demonstrated overall limited data suggesting any difference in effectiveness of either dolutegravir or bictegravir based ART regimens compared to raltegravir plus Truvada in preventing HIV seroconversion, although this was primarily studied in non-occupational populations. There was also the possibility of an increase in adherence and a decrease in adverse events associated with either of these two regimens compared to the raltegravir regimen. Additionally, these drugs have been used for years now in treatment settings and represent first-line treatment options for HIV-infected persons that are safe and effective. And so ultimately, these regimens both minimize side effects and also the number of pills needed to take on a daily basis. So we also have a number of alternative PAP regimens if for whatever reason one of the recommended options would not work. And so we'll go through those here. First, we have regimens that include are based with a protease inhibitor plus 2 NRTIs. And so that would involve here 2 darunavir-based regimens. The first is Prescobex, so that's 1 pill once a day, which is a darunavir boosted with cobicistat, plus emtricitabine or lamivudine, otherwise plus tenofovir alafenamide or tenofovir DF. And then the other option is Simtuzo, which is 1 pill once a day. That would include darunavir, cobicistat, and then tenofovir alafenamide, specifically with emtricitabine. Another category here would be an alternative regimen including an NRTI-based regimen plus 2 NRTIs. And so here we have Delstrago, which is 1 pill once a day. That includes the NRTI called doravirine, along with tenofovir DF and lamivudine. Another option is doravirine separated out from that combination pill, and then adding in the emtricitabine or lamivudine and tenofovir as separate pills. And lastly, for alternative regimens, we have other integrase or INSTI-based regimens. So that would include either Genvoya or Stribild. Both of those contain the INSTI called elvitegravir, which is boosted with cobicistat. Genvoya is the first one that has tenofovir alafenamide, whereas Stribild has tenofovir DF. Or the older regimen now from 2013, which is currently the preferred regimen. And in this case, we have raltegravir plus emtricitabine or lamivudine plus, again, one of the 2 tenofovirs. We also created a draft list of preferred regimens for recipients with kidney disease, which we stipulated involves a creatinine clearance greater than 5 or otherwise on hemodialysis. And so here we have one of sort of 3 categories of options. We have the integrase-based regimens. So those would include, again, either dolutegravir plus dose-reduced emtricitabine or lamivudine plus one of either dose-reduced tenofovir DF or tenofovir alafenamide. Or again, we'd have raltegravir involving the same dose reductions with emtricitabine or tenofovir. For PI regimens, we have Prescobex again, which would be darunavir plus cobicistat, and then either dose-reduced emtricitabine or lamivudine plus dose-reduced tenofovir DF or tenofovir LF-enamide. And then lastly, another option would be doravirine plus dose-reduced emtricitabine or lamivudine plus dose-reduced tenofovir DF or tenofovir LF-enamide. And then also have a draft recommendation here for preferred PEP regimens for pregnant healthcare personnel. And so essentially here, what we recommend, these are the same regimens that would be recommended for non-pregnant patients with several exceptions. First of all, Biktarvy would be recommended as an alternative due to currently incomplete data available on the pharmacokinetics of Biktarvy in the second and third trimesters of pregnancy. And then additionally, regimens that contain cobicistat, such as Genvoya or Stribild, would not be recommended due to reduced plasma drug exposure in pregnancy. So now I wanted to review draft recommendations for PEP in the setting of exposures to source patients who have HIV, as well as an undetectable serum viral load. So for healthcare personnel who have an occupational exposure to HIV and the source patient is known or found to have an undetectable serum viral load, first, HIV PEP should be offered to exposed healthcare personnel. And second, the decision to not take or discontinue PEP early should be made on a case-by-case basis with shared decision-making involving the exposed healthcare personnel. Next, I wanted to review draft recommendations for laboratory testing of exposed healthcare personnel. So as in 2013, we recommend baseline laboratory tests of exposed healthcare personnel to be performed as soon as possible after exposure, which would include first a rapid or lab-based fourth generation HIV antigen antibody combination immunoassay, as well as baseline serum creatinine, and then AST and ALT testing. For follow-up testing, we would recommend first an interim test to occur at weeks 4 to 6 post-exposure, with both the lab-based HIV antigen antibody combination immunoassay as well as qualitative nucleic acid test, or NAT. This would be recommended for all healthcare personnel who are exposed who had PEP initiated over 24 hours after their single exposure or who missed any PEP doses. The final test would occur at week 12 post-exposure with, again, both the HIV antigen antibody combination immunoassay and the qualitative NAT for all exposed healthcare personnel, regardless of PEP administration or adherence. Routine follow-up testing of serum creatinine, AST, and ALT is not necessary unless baseline tests are abnormal or there are clinical indications that may occur over the course of PEP, such as signs or symptoms concerning for kidney or liver injury. And lastly, just wanted to review draft recommendations for when expert consultation for HIV PEP is recommended. Be a little easier to show on the next slide, but just to say that obtaining expert consultation should not delay timely initiation of PEP. And so we'll just briefly go through these situations. So either, so any of the following essentially would be situations in which expert consultation would be recommended. So first, either if you have delayed exposure report, so in other words, later than 72 hours. If there was an unknown source, such as a needle and sharps disposal container or in laundry. If there was known or suspected pregnancy in the exposed person, or if the exposed person was breastfeeding. If there was known or suspected resistance of the source virus to antiretrovirals, that would be recommended in order to come up with a best recommended regimen. If there was toxicity of the initial PEP regimen and a switch might need to be considered, for example, during the course of PEP. And then also if there's serious medical illness in the exposed person due to, for example, renal disease, or if the exposed provider is already taking multiple medications that might increase the risk of drug toxicity. And then a number of resources for expert consultation for PEP are provided as well and listed here. So that with that, I'll stop there and be happy to take any questions. And otherwise, thanks very much for listening.
Thanks, Aaron. I'd like to open it up to any questions or comments from members on Aaron's presentation. Judy.
Thanks, Erin, for reviewing those draft recommendations. One question that I could see coming up is on the slide for a situation where there's an exposure of a healthcare worker to a source patient that has an undetectable viral load. I could see the question coming up, what would be the time window of that documented undetectable viral load? Are we, is the recommendation to to check a viral load on the source patient on the day of the actual exposure and use that laboratory result to make that shared decision making? Or would there be a window, say 3 months within the time, before the time of the exposure, et cetera? Thanks.
Yeah, thanks very much, Judy. So, currently in terms of where we are in our review and having looked into this question, there really isn't much data to guide an easy answer to that question, or in general for source patient viral load testing. You run, the risk if you test on the same day. You might get an answer, but what if they're in a window period, for instance? Low likelihood, but still possible. Realistically, the way we're sort of thinking of framing this is essentially, it would be discretionary, and how that test would be, how that knowledge of their undetectability would be interpreted essentially would be discretionary on the basis of the expert that would be involved. But that's why we don't have a recommendation for its use, and why as sort of a general maxim, we're recommending that PEP still be given.
Okay, great. Thanks. I know it comes up when I get questions for maternal child PEP. If a woman comes in labor and, she has a rapid positive test or has known HIV infection, but doesn't have a documented viral load for a while. So I bring that up because it's kind of a similar situation. So thank you.
Yeah, sure. Thank you.
Any other questions for Erin, including from ex officio members and liaisons? I don't see any hands. So